Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Hello, welcome to Doc Discussions. This is Jason Edwards, and I'm here again with Dr. Lisa Ryan, a pediatrician at Woods Mill Pediatrics. Phone number is 314-453-9666. Lisa, welcome. How you doing?
Hi, good. I'm glad to be back.
Yeah, good. You were great last time. I thought you were really great on the mic, and so I thought we could get into kind of maybe a somewhat controversial topic of vaccine hesitancy.
Okay, yes, that's a big one, an important one.
Yeah, so, my assumption is that this is something that pediatricians have kind of dealt with more and more as the years have gone on. Is that accurate, or has it kind of been more popular and less popular? Or?
No, I think that's fair to say that things kind of ebb and flow. Recently, we're really in a spot where we're seeing more and more vaccine hesitancy. People are asking more and more questions, and we're seeing more and more vaccine refusals. And sadly, we're seeing some of the consequences of that too.
So, what are some of the common misconceptions patients family members have about vaccines?
First of all, it's really hard to say because typically, if a family comes in, it's hard to kind of pinpoint exactly what they're concerned about. I'd say probably the biggest one, though, is they're worried about too much at once.
Okay.
So they see us giving, a couple of shots at one time, and they get very concerned that, I have this brand new tiny baby, and we hear often that you're going to overwhelm the immune system. So I'd say that's probably the biggest concern. We sometimes people will come in with arguments that the vaccines are actually harmful. I don't think we hear that one quite as often.
Okay.
Or that they're not studied well. Again, I don't think we hear that one quite as often. But truthfully, I almost feel like it's sort of this gut feeling that it's something that I don't think my baby really needs. And in my mind, there is some negative outcome that weighs any possible benefits. And sometimes I don't think they're even able to really verbalize what they're worried about or what they think might happen.
Yeah, it reminds me of a book by Daniel Kahneman called Thinking Fast and Slow. And like most books, I read like half of it. And then, most books, they you get the gist of it, and then they just pound the same point home for another couple hundred pages. But there's this emotional knee-jerk thinking, which is good. Sometimes you don't have all day to think about something. And then the slow thinking is this logical, methodical thinking. If you can break it down into math or physics, you would do that and try to figure out what the best answer is. And I think, the idea of seeing a newborn baby getting needles stuck in it, whether it's one needle or 10 needles or 15, it's not a good feeling. Sure. And so it seems like it's kind of that fast knee-jerk feeling that hey, this doesn't seem right, even though we've been doing it for a really long time.
Right. There's also a lot of studies looking at vaccine hesitancy, similar to what you were saying, that the idea of actively doing something is a harder thing to take on than the idea of just kind of sitting back and seeing what happens.
Yeah.
The parent would feel more guilt if I made this decision and something happened rather than let me take my chances.
Yeah. Okay. I get that. And so that's like a type of cognitive dissonance. Mm-hmm. And so, it feels unnatural. Sometimes it's better to, you want to just sit back and kind of let things play out, and then you would have kind of less guilt on your heart, despite whatever the outcome may be.
Sure. And the other part of that too is we'll say often that vaccines are a victim of their own success. A lot of these vaccine preventable illnesses we just don't see anymore. A parent doesn't even know. I mean, you say, hey, your baby might get measles. They're like, okay, so my grandparents had measles, my parents had measles, nothing terrible happened to them. Or, we vaccinate against chickenpox. I had chickenpox when I was small. I had a mild case. I seem fine. So, I think a lot of it is just very far removed. Polio's been a lot in the news recently. And, I guess it's our grandparents at this point, remember these springs or these summers where, your neighbor could be in the iron lung tomorrow because they had polio, and how scary and how fearful that was. And that's just, parents just don't see that. It's just that fear is not there. They think it's so far removed that, again, they're willing to take the chance.
That makes a lot of sense. And that's a good point. You know, when I think of polio, I think of FDR, of course, but you know, we don't see people with polio.
Right.
And I think maybe I've seen one patient ever with it. But it's just not something that's present. If it's in your face, then fear drives a lot of decision making.
Of course.
And so, you know, you read something online and it's scary despite not really having the context of it. And that can really be your anchoring bias. It's the first thing you see, the first thing you think of, and it's just hard to move off that position.
That's true. Or you just don't fully understand, fully comprehend how it works.
Yeah.
And I've had, patients talk to me about that too. And the best analogy I've come up with there is, you know what? I don't enjoy flying. I'm a nervous flyer. It does not make sense to me at all how this giant plane is going to get off of the ground and get me safely to my destination. However, at some point, I have to trust that, the engineers built this plane, that all the people have checked the plane out, that the pilot knows what he's doing, and I have to sort of give that over to him that he's going to get me safely to my destination. So at some point, too, I say, you got to trust the experts. People have been doing this for a long time. They know more than we do, and we have to trust what they're telling us. And there's a lot of distrust now.
Yeah. And that's a great point. I mean, the airport bar is typically full of people, taking a shot of tequila at 8 a.m. because it's nerve wracking, even though per mile, it's obviously safer than driving in a car.
Right.
But it's just that thing in your head that, it gets stuck there. It just doesn't it's scary.
Mm-hmm. Or it's a little bit out of your control.
Yeah, for sure. And so, how have the number of shots that children get changed over the years?
So that's a really good question.
Generically.
Yeah. So basically at most visits, babies are now getting 2 injections and a little syrup that they drink.
Okay.
And because we have combined vaccines. So one of those vaccines is going to give you a DTaP, a Hib, and a polio vaccination all in one shot.
Yeah.
And, your DTaP, that is, already 3 different vaccines. And then, your Hib and your polio. So now that's 1, 2, 3, 4, 5 kind of all in one.
Yeah.
And then your Prevnar vaccine in another, and then your rotavirus is the drink. So that was 6, 7 things we're vaccinating against kind of all in once.
Okay, but it's 2 shots in a drink.
Correct.
Gotcha.
Correct. So, sometimes you'll just see all those, depending how you look at it, if you see all of that sort of laid out in front of you, it does seem overwhelming. It does seem like a lot of stuff.
Yeah.
But what we've been able to do over time is actually the exposures from all of those is much less than when your baby is born and takes his first breath. The antigens in there's just much fewer.
Got you.
So we're able to sort of refine things that way. So even though it seems like a lot and it seems like it's more, it's actually technically a little less.
Gotcha. It's less of a load, less of a challenge to the system.
Mm-hmm.
So if I was like kind of playing the role of a skeptic, and said, this seems like it's too much. It seems like it's overwhelming the system, which I get. A very rational person could say that. Then you would think that children would be, if the immune system was kind of biased in this way because of the recent vaccination, meaning that it's making these antibodies towards the antigens that you just gave it, that if it was overwhelming the immune system, then they would be prone to other illnesses.
Sure.
Right?
If your immune system is busy doing one thing, you're saying
That's
that
right.
it wouldn't be able to do the other stuff. Right.
And so you would expect that the rates of not only influenza, but all sorts of things would increase. And I don't think there's any data to support that children get sick more often, from the normal culprits. Is there?
Sure. No, definitely not. I mean, most of those, it obviously ebbs and flows with the season.
Sure.
And COVID kind of threw stuff out of whack, so it's become a little harder to predict. But we're certainly not seeing kids sicker than we ever had before. I mean, truthfully, the sick season is much calmer than it's ever been. I mean, we used to bring in 18 kids with RSV, but now we have an RSV vaccine, and I've seen maybe 4 this year.
When did that come out, the RSV?
This, I want to say, is the 2nd season.
Really?
Yeah.
I had to do a pediatric oncology rotation, and that was and it was in the wintertime, and that was it was a big deal, and these kids were really sick, and some of them had chemotherapy, some not. But I mean, the RSV was, to me, very scary.
Well, as a resident, that was a big deal. That was kind of what you were there to learn, because we would admit these kids overnight, and usually most of them were able to go home the next day. Some of them might stay a little longer, but that was what part of pediatric residency was, being able to admit all these kids, being able to recognize which kid was sick and would need more help, and being able to figure out which ones were good to go, the next day and when they were ready to go home.
Yeah.
But we used to, during the busy time, we'd have like 20 admits at night.
Yeah.
And I know that Children's Hospital is like overflowing now, and I think all the hospitals really are with various other viruses and stuff. But I haven't had a hospitalized RSV kid this year.
Yeah. So yeah, that's great. For me, being a non-pediatrician, kids are much more resilient than adults. I remember seeing a patient with leukemia who had like a hemoglobin of like 2. You're not surviving that as an adult.
Right.
A kid, 2 weeks later is like running around.
It's the best part of pediatrics.
They are resilient for sure. And so, are each is each vaccine tested in randomized controlled trials before they use it?
Yeah.
And they're large randomized controlled trials, right?
Right.
And that's kind of the gold standard for any drug or vaccine, is to use it on a lot of people and then follow those people and see what happens.
There's some caveats there, because obviously we don't want to leave kids prone to getting these infections if we've realized that the vaccine is going to help them. So the randomized controlled trial might be slightly different than it would be for some kind of drug or something like that. And I think we saw that to some extent with the COVID vaccine. We had controls and we had people who were on it. And once we realized it was going well, they were able to kind of stop and just start vaccinating everyone.
Yeah, okay. And so what you're saying is, if there's obvious evidence or strong evidence or a strong suggestion that it's working, there's not this group that doesn't get it. Right. Because you would be kind of doing a disservice to that group, but you could at least compare them to historical controls that did not have that.
Sure.
Which is pretty good.
Yeah. And of course, we're kind of following along, and we're looking to see if there's any negative side effects. The rotavirus vaccine, actually, there used to be 2 versions of the rotavirus vaccine. And one of them, they started to see an increase in intussusceptions, which is kind of where the intestine telescopes in on itself.
Yeah.
And, I don't know that they were necessarily able to say that it was causing or that sort of thing, but there was enough of a signal there for them to actually, that one got pulled from the market, and now we only have this other one.
So I read that drugs, just all drugs, not pediatric drugs, not vaccines, but just drugs, about 25% of them will end up having like a black box warning, and about 2% will get pulled from the market. Has that happened with vaccines at all?
Doc Discussions with Dr. Jason Edwards. Brought to you by St. Luke's, St. Louis.
The Rototech is the one that really stands out. Some of them have been refined. Like it was the DTaP vaccine, the pertussis component of it used to be sort of a bigger antigen.
Okay.
I have to admit, I don't remember the specifics
about it. But they made it better.
But they changed it because there was more side effects to that particular part. So they were able to go back and kind of rework it. And that's why we now have the DTaP as opposed to the DTP.
And that's been around forever.
Yeah, it's been quite some time.
Yeah.
But I haven't been doing this all that long. And I can still remember, when I started practice, the HPV vaccine was coming out and the rotavirus vaccine was coming out. And just even in the short time I've been in practice, when I was a resident, we would admit tons of kids with rotavirus, and I haven't seen rotavirus in ages since we got everyone vaccinated.
That's a virus that causes a lot of diarrhea and things
Correct.
like that.
Yeah, kids would get admitted for dehydration like all March. Like that was how we spent our March, and I haven't seen rotavirus in a really long time.
And so, in a way, you could say, well, that's kind of scary. This vaccine, this rotavirus vaccine, the initial one got pulled. But also, it should also give you some comfort that they're monitoring these things closely. And if there is an issue, they will pull it quickly.
Right. There's, and a lot of the vaccine skeptics kind of point to this too, this database where people can submit their, what they believe is a vaccine side effect.
Yeah.
And a lot of skeptics will say that, we submit all of these and these are all very real side effects. And because they're all there, we need to be looking at these vaccines more closely and stopping use of them.
Yeah.
But what actually happens is once those side effects are in there, there's someone who's going through and really, analyzing, is this actually due to the vaccine, and looking at the science behind it before they make any sort of decisions about it.
Yeah. So this is, Sir Bradford Hill talked about this a long time ago. It's causation versus association. And so you're going to have, if you have a group of people vaccinated, whether it's a COVID vaccine or a flu vaccine or, your childhood immunizations, things will happen to people in both groups, whether you're vaccinated or not.
Right.
And actually, this is a good example. So patients who have had hormone replacement therapy, estrogen, have a higher risk of breast cancer. And according to the old data, your relative risk would double. And so if you're a woman in the United States, your likelihood of getting a breast cancer is about 17%, let's say 16. If you take hormone therapy, they used to think that your risk was double, so it would be 32%. But 100% of women who took estrogen replacement and got breast cancer thought that it was from the estrogen.
Sure.
And so, but even though it was only half the time you would have gotten it anyway.
Right.
And so there's all these errors in judgment that people have. And I think it's fascinating to study that. And I have them, and you have them, and everybody has them. But if you actually, know they exist, your likelihood of making mistakes starts to go down. And I think that's where errors in judgment can occur. You take everybody who takes the flu vaccine every year, there's going to be people who die the next day. But there's also going to be people who didn't take the flu vaccine who die the next day too.
Right.
Now, if you're the person who takes the flu vaccine and dies the next day, good luck trying to convince that person that it's a coincidence. I mean, when a coincidence happens to you, it does not feel like a coincidence. You see direct cause and effect. And that's what's hard for, you hear these anecdotal stories, and that's what's hard for people to separate. I mean, you're just not going to be able to convince that individual that it's unrelated.
Yeah, no, you're exactly right, because that's sort of the last big thing you remember. I've talked to patients too in terms of, I'll be like, okay, let's pretend that, your baby is all ready to get his vaccine, and he's on the table, and I've got his leg, and I've got the vaccine ready to go, and I'm about to put it in his leg, but I get distracted and I turn around and I don't do it yet. And then all of a sudden your baby starts having a seizure. If I hadn't turned around and I had done the vaccine right then, your baby was going to have the seizure either way, but now you're convinced it's caused by the vaccine.
Yeah.
And it's, it goes back to some of these ideas we haven't touched on yet about the MMR and autism. And a lot of that has to do with the same time you're giving the MMR vaccine is around the time that we're diagnosing autism.
And what age is that?
12 months.
12 months.
So at 12 months, everybody's getting the MMR vaccine.
And so this really came in the late 90s when Andrew Wakefield, I think he was an English physician, came out with a study showing that vaccines were associated with autism. Later, I think it was found that the data was manipulated.
Yeah, it was flawed.
Yeah.
So I think it was like 1998 or so. He had two studies. So the first one came out, and if I remember correctly, it was published in the Lancet. And it was basically making an associate, or his hypothesis was that when you give the MMR vaccine, you cause proteins to enter through the digestive tract. Like we cause inflammation in the digestive tract, which allows proteins to enter, which then later cause autism.
Yeah.
So that was kind of what he set up. But it was flawed in a lot of ways. I think the sample size was super small. I think he had used like friends from his kid's birthday party or something. Like there was something really weird there. And as you know, science has to be replicated, and no one was ever able to see these same results.
Yeah. And yeah, for sure. I mean, especially in the social sciences, they have a very difficult time replicating studies, which, should make us somewhat suspicious. About that kind of stuff. But in that doesn't happen very often with medical trials.
Right.
Usually if a large sample size, it's reproducible.
Right.
Not always, So other people tried to do the same trial and were not able to replicate it.
Right. So it wasn't, they couldn't replicate it. And when they went back, it's just the whole study design was flawed. And so like the Lancet actually removed it. So it's as if it never existed. But of course the damage was already out there.
Yeah.
And I believed he published a second paper. It was like 3 or 4 years later with kind of similar findings. Again, I don't remember the specifics, but it was something about seeing measles virus in cells in the intestine. Okay. And so again, he was associating that with the vaccine, but without.
That's a pretty big jump.
Yeah. So yeah, the damage was done. And I think that was around the time that people started questioning these things. I mean, my oldest, she was born in 2003. And I remember, being a little like, okay, I've sort of heard these things, and asking her doctor, but we're doing this, like this is safe to do. And him being like, yeah.
And so like, yeah, you have, like you would say, you had a little bit of skepticism.
Yeah.
And like, I would say like, it's okay to be, to ask questions.
Right.
It's okay to not, to be like, this feels weird.
Mm-hmm.
I think it's, and you and I talked about this earlier. Practices sometimes don't, if the patients say, I do not want to get vaccinated. A lot of practices, I would say the majority of pediatric practices actually say then we can't be your doctor.
Yeah, we're just not the right fit. We're just not the doctor for you.
Yeah.
And our practice is one that's like that. And it wasn't a decision we came to easily, but it's one that I feel pretty strongly about. I mean, first of all, I want to be able to protect all my patients in the waiting room. If I have a baby in the waiting room who isn't old enough to be vaccinated or can't be vaccinated due to a medical issue, I want them to feel that they're not going to come into my office and catch a vaccine preventable illness.
Yeah.
So that's a big part of it. But the other part of it too is I think it's just really hard for me to form the doctor-patient relationship that patient needs. I guess in my mind, I think one of the very best and most important things I can do for your child is ensure that he's vaccinated.
Yeah.
And if I'm trying to do that and you don't think that that's the best thing for him, if you think that if I vaccinate him, I'm poisoning him or inhibiting his health in one way or another, I don't think you would trust me with any other medical decision. And I think there's already a distrust there. So, like if you come in for a ear infection, I say, hey, amoxicillin's the best med for you. Are you necessarily going to trust that either? Like, it seems like for everybody, you should be going somewhere where you trust what your doctor's telling you.
Okay.
And feel comfortable with that.
So it's not like coercion or punitive. It's just a bad fit.
I think so.
And it's just kind of like say, hey, like, I wish you the best, but, we got to kind of part ways here.
Right. Well, and the other thing is, sometimes parents will come in and be like, I only want the most important vaccines. And I'll be like, well, how do we decide what is the most important? And I'm not saying it flippantly, but it's like,
there's not a ranking, right?
Well, yeah. Is the most important one the one you're most likely to get? Is it the one you're most likely to die from? Is it the one that has the most painful death? Like, how are we going to decide that? I don't feel comfortable making that decision.
Yeah.
We have people who reviewed the vaccine schedule. They've figured out what order it should be given in order to make sure that we're protecting you from the earliest stage possible. There's just no reason to stray from that.
Yeah. And so I'm going to go, we talked about autism. Mm-hmm. I'm going to go just a little bit off topic for a second.
Okay.
Why do you think that there's an increased incidence of autism?
We screen for it more.
Yeah, that's what I thought.
Yeah, and even that I think has been over the course of my career too. Like when I came out of residency, it was something that, it was kind of in the back of your mind and you would sort of, we obviously always talk about development.
Yeah.
But at some point, I don't remember when. I mean, we do very specific screens at 18 and 24 months.
Yeah.
So not only are we talking about development at every visit, but they've now created a questionnaire that parents will fill out and it can basically signal is this someone who's at risk. So I think we're just picking it up more. It kind of extended the definition. I think it used to be a very narrow definition and now we've made it much wider, realizing that people benefit, even if they don't meet the narrow definition of autism, they may still benefit from the therapies if we widen that definition.
So you don't think that there's been some sort of evolution of human beings where like the trait is just more abundant than it used to be in our population? I know that's a tough question to answer, but
I mean, I think there's a genetic component? Probably, yes.
Yeah.
But I just think it's I don't think it's more prevalent for those sorts of reasons.
Okay.
I really think it's just more changing the definition and just more awareness. You're more likely to see the things you're aware of and looking for.
Yeah, it's kind of my presumption that the more experts you have in autism in a population, probably the higher the incidence will be.
If you're a hammer, you see a nail.
And so, what was that? I'm sorry.
If you're a hammer, you see a nail.
Yeah, I mean, a little bit of that. I think back growing up, and I mean, there are kids that, now I'm not an expert on autism, but there are kids that we all do this. And I kind of, sometimes I'm like, it's okay. And sometimes I don't. When you're like, oh yeah, he's on the spectrum. Something feels a little off. It's kind of become socially okay to do that.
Right.
And I don't know. I don't feel 100% about that. But we all know people who were like, okay, like maybe that guy was autistic that I grew up with. And still everything was fine. We still lived a good life. We're all different in every way. But now like that person would probably have a diagnosis.
Right.
Yeah.
And, and for what's that worth, it can get you services, it can get you help at school, it can make things a little bit easier for you. So I think in some ways, and I'm not saying this necessarily happens, in some ways, I think if you're on the edge, it might be worth just doing it so that you can get that help.
Yeah.
So maybe that alone accounts for, a little bit more. I mean, I've certainly sent kids for evaluations where I'm pretty sure they don't have it and they definitely come back with the diagnosis. So
do you think, I mean, on something like that it's not like a blood test you get and you have this like result, yes or no. It's, kind of a judgment call based off a multitude of things. Do you think there's an overdiagnosis of it? I mean, there's got to be to some degree, but do you think like that degree is large or small?
I mean, I think it's hard to use the word overdiagnosis. I mean, I think I'm thinking of patients where I'll be like, I don't know that this is really autism. This seems more about like a developmental delay or, maybe an isolated speech delay, but they end up getting the diagnosis of autism. They end up getting the ABA therapies as well as other intensive therapies. And within a couple of years, they're actually, back in a realm where you wouldn't see any deficits.
Yeah.
So was that really a diagnosis or did they get better because of the help? I'm not really sure.
Yeah.
Either way, I'm happy they got better and, we don't have to worry about it. And I don't think the diagnosis necessarily like follows them or anything like that. Mm-hmm. But I think because of cases like that too, like I said, I think we are maybe a little quicker to call this autism so that they can get help, which we know will be helpful.
So the thought is to err on the side of giving it to them, the diagnosis to them, than not.
I think I see that sometimes. Yeah.
Like a soft call.
Sure.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.